So good morning, everyone. Happy first day of summer. Thank you for being here. Before we get started, I'll just do the same reminders I've been doing. Make sure your full name is in your Zoom profile so we can count your attendance. We welcome you to have your cameras on, please. Please be respectful and attentive of our speakers and your fellow students. Please keep yourself muted when not speaking. If you want to speak, you can use the raise hand function and we'll call on you. And you can use the chat function to ask or answer questions, and we'll do our best to get to all of them, time permitting. So our first presenter is Dr. LaValley Willsey. She is a full-time OBGYN with Camilla Women's Health. She is the president and part owner of the practice and has been the chair of obstetrics and gynecology department at Mercy San Juan Hospital. Welcome, Dr. LaValley Willsey.
Thank you. Good morning, everybody. As Sam said, I'm Dr. LaValley Willsey. I am full scope OBGYN in private practice here in Sacramento with Camilla Women's Health. And I am happy to chat with you guys about, what my life is like, what my education was like, all of that. If anybody has any questions to start, otherwise I can kind of jump in and explain how I got to where I am. All right, I'll jump in. So I actually grew up in Northern Nevada over in Lake Tahoe area. So after high school, I went off to college in New York City. I thought I wanted to be an engineer, and turns out I can't do calculus. So I had to kind of redirect what I was going to do with my life. And I spent some time thinking and wasn't really sure. And some people suggested, well, why not pre-med? And so I went ahead and did that, not really knowing what I was getting myself into. I think a lot of people have kind of like a lifelong dream of being a doctor for whatever reason, whether it's their families in medicine or they have an experience with the healthcare field earlier in life. But for me, it was kind of sure, let's do that. So I did my pre-med in New York. I got into medical school in Nevada, which was home state, which was really nice to go back home. And after 4 years of medical school, I went off to residency in Phoenix, Arizona. And from there, I joined Camilla Women's Health here in Sacramento, and I've been there ever since. It's been 13 years this summer. So it's been a little while. In terms of medical school, I thought I wanted to do family medicine or pediatrics. That's kind of where I was headed. I thought I wanted to kind of do all of the things, take care of people through their whole lives and not really do surgery. In medical school, the first 2 years are all like classroom based. So you're just learning the basis of disease and physiology and pathology, kind of learning the background of how things work for the human body. And then the second 2 years are in clinical practice. So you go and work with different specialties to decide what you might want to do. There are several required rotations. OBGYN was a six-week required rotation. I thought I was going to hate it. It had a terrible reputation. I thought it was just going to be terrible, but I could do anything for 6 weeks. And about 2 weeks in, I decided that I just absolutely loved taking care of women and all of the things that they need. And I love doing surgery, which was a surprise to me. I never thought I would like surgery. So I opted to go into OBGYN. OBGYN residency is 4 whole years after 4 years of medical school. So 4 years of specializing in OBGYN, and then you can go off and apply to wherever you want to apply. And I happened to get a job with this fabulous private practice that is physician owned. And now I'm a part owner of the practice as well. So that's pretty exciting. I've been at Mercy San Juan since I joined Camilla Women's Health. We did have privileges for a while at Sutter downtown as well. Now we're mainly just based at Mercy San Juan. I do full scope OBGYN, which means that I take care of women's health, both in the office and in the hospital. I take care of younger women with birth control or period issues or pelvic pain, whatever issues they might have. I do preventive care, which is wonderful to help make sure that patients can continue to live a healthy lifestyle, not just take care of problems when they arise. I'm fortunate that I'm also able to take care of pregnant patients and deliver babies. That is certainly a highlight of my job, both doing vaginal deliveries and C-sections. And then I also get to do gynecologic surgery, which is fantastic as well. So both minor surgeries and major surgeries. I had a hysterectomy yesterday morning before I went off to the office for the day. I get to take care of women throughout their lives, take care of their family planning, birth control issues, period issues, help them with their pregnancies and deliveries, take care of them as they go through menopause transition, kind of the whole thing. So it's a really wonderful field of medicine. It's very unique in that I get to both do surgery, but also establish long-term relationships with my patients. And I really love that about it. So that's kind of the general what I do and how I got here. You guys have any questions?
I'm going to start putting some questions in the chat while they think about theirs.
Yeah.
So what advice would you give a high school student interested in pursuing medicine?
I think my advice would be to be open and make sure that you're doing other things, right? Because you might think you want to do medicine and you end up not liking it, or it might absolutely be your passion, but if you don't have a well-rounded life, then you're not going to be happy even if you do the thing that you want, which is medicine, you know? So make sure that you're doing other things and not solely focusing on, I must get into medical school, I must get into medical school. Do the other things, you know, have friends, go to parties, enjoy college, study interesting things, literature, a foreign language, whatever it might be, in addition to the science to get into medicine, because there's a lot more to life than just being doctor.
All right, we have some questions showing up, but what does your schedule look like day to day?
My schedule really varies. So, and it varies depending on what kind of a practice you're in. So I happen to be in a private practice where as a group, we decide to work 4 days a week. So typically I'll have, usual week is 3 days in the office. So those days are typically like 8:30 to 4:30 in the afternoon. I'm seeing patients in the office. I have a lunch break. You know, those are kind of my chill days. We also do 24-hour calls once a week. So I'm at the hospital for a full 24 hours, 1 day per week. So that is it's a fourth day of work, but it's really kind of 3 days in one. On those days, we arrive by 7 a.m., take care of all of our delivered patients on postpartum, take care of all of our laboring patients, make sure that everybody's having a safe delivery, whether that's a vaginal delivery or a C-section, and just kind of take care of the entire labor and delivery unit, as well as any gynecologic issues that might come into the emergency department. So if there's any, you know, there are GYN emergencies that can come in that we have to take care of. So I'll do that as well. Every couple of weeks, I'll have a day in the operating room where I get to do surgery all day. And that's really fun and exciting. I really enjoy doing surgery. We operate together with the other partners in my practice, which is really nice. There's always 2 of us working together. So we have a really collaborative practice, and we, you know, help teach each other and mentor each other. So yeah, it just kind of depends on the day and what kind of practice you're in, but that's generally speaking what my days look like.
And kind of playing off of that a little bit, what does flexibility look like in your job?
So again, fortunately, I'm in a private practice and I own my practice with my partners. And so I do have quite a bit more flexibility than I would if I worked for a big corporation like Kaiser or Sutter. And that's not to say that those are bad places to work. It's just a very different model where you have a boss and they tell you what to do. In my situation, I am my boss. And so I can be flexible. So I can just tell my scheduler like, hey, on Tuesday, I need to be done by 3 p.m. so I can take my son to soccer or whatever it might be. And that's absolutely what I can do. And that's really wonderful. Big picture flexibility is important as well. Again, in my case, I'm in private practice. I can decide what I want to do and what I don't want to do. So for example, there's a type of surgery called a hysteroscopic surgery where you put a small camera in through the cervix into the uterus, and you can do surgery inside the uterus that way. I hate that kind of surgery. My partner, Dr. Dawson, loves that kind of surgery. So I can be flexible and say, I'm not doing that. You can go see my partner and that'll be wonderful. Likewise, she can send her patients to me if they need robotic surgery, which I do and she doesn't do. So I actually have quite a bit of flexibility, but it really depends on where you work and what you're looking for. But generally speaking, there is quite a bit of flexibility. A lot of OBGYNs now, I think, are more becoming a little bit more specialized or focused on one area. So kind of a newer field of OBGYN is being a hospitalist. That's kind of popped up in the last 15 years, maybe, where physicians will literally only take care of labor and delivery patients. They don't have an office. They don't go to an office, which means they don't get to follow up and establish long-term relationships. And they can just work shifts, which is both good and bad, right? Depending on what kind of a lifestyle you're looking for and what kind of a thing you're looking for. But if you go into OBGYN, you can be flexible and choose to just take care of labor and delivery patients, or only do GYN surgery, or only do office and never see patients in the hospital. And you can furthermore, you can specialize or subspecialize beyond OBGYN into urogynecology, which takes care of prolapse issues mainly, or GYN oncology, which is female cancers. You can specialize in maternal fetal medicine, which is high-risk pregnancy care. So there's actually quite a bit of flexibility depending on what you're looking for.
Okay, one that came to me. How do you cope with the stress?
That's a fun question. It can be really hard. This is a really stressful job. I won't lie. It is very stressful. And sometimes I daydream about like being a stalker at Barnes and Noble with no responsibility, but that's not the life I chose. I think I've finally kind of gotten better at it. I have 3 children. They're finally old enough that I feel like I'm out of the trenches. So now I do try to focus on making sure I get exercise in, making sure I get outdoor time. I read books rather than watch TV, and I think that's big for me personally because I like reading. Really, you have to find the things that have nothing to do with medicine that you love and make sure that you put the effort into making sure you can continue them.
Okay, it's kind of a long question in the chat, just 2 parts. What would you suggest to someone who is unsure about what career they want in the medical field regarding deciding a subfield or specialty? And beyond that, would you suggest shadowing and doing internships with multiple branches of medicine?
Yes, so the answer to part 1 is, like I said, in medical school, the first 2 years you do the basis of disease. You learn, normal physiology, you learn pathology, you learn the molecular basis of things. You learn all of that stuff, the book stuff. And then the second 2 years of medical school, especially the 3rd year of medical school, you're doing required rotations in the major specialties. And so, so I think it's important to keep an open mind for those because you literally don't know what you want to do. Like I said, I thought I was going to do family medicine or pediatrics. Those 2 rotations bored me to death. I loved OBGYN and I never thought I would like it. So going into it with an open mind and realizing that that you have a lot of time to choose. You don't have to go into it knowing what you want to do. And I think it might be a disservice to yourself if you stay closed-minded like that and say, I am going to be a urologist no matter what, because my father was, or my uncle was, or my aunt was, or whoever. I think that's going to do yourself a disservice. You really need to go into it with an open mind and experience all the different specialties and see what sticks, see what interests you. I guess the second part of the question was about doing like internships or shadowing. I think that's super helpful because as a patient, you all are patients at this point, and you probably have limited experience within health. If you can go and shadow doctors and see what they do, it can really help illuminate what you might want to do for your life or what you don't want to do for your life. So I think if you have that opportunity, absolutely take it. Go shadow some doctors, different kinds of doctors, see what parts of their job you like, what parts you don't like. And even like the type of job, if you shadow somebody at a big corporation, you might say, I love what they do, but I hate that they have to do it, how the corp tells them to do it. That might be a thing. Or you might shadow a private practice doctor and be like, wow, I love what they do, but I hate that they have to make business decisions. And it can be really illuminating. So if you have the opportunity to do internships or shadowing, absolutely do it. If you don't, that's not the end of the world either. You will get that chance in medical school.
All right. What's the hardest part of your job?
That's a tough question. I own a business, and that is not what I went to school for, and that's not what I trained for. So that is one of the harder parts of my job, is making those decisions and taking care of that part of it. Clinically speaking, the hardest part of my job is telling a patient that she has lost her baby. That is my job, generally speaking, is a very happy job, and I get to be there for the best moments in people's lives. And now and then I have to be there for the worst moments in their lives. And that's clinically, that is absolutely the worst part of my job.
All right. Who helped you along the way? Like, who were your mentors?
So like I said, I didn't go to college thinking I was going to do pre-med or medical school. So I was a little bit late in the game. I think if you know earlier, you can establish mentorships and support earlier to help you get through that. I really didn't know what the heck I was doing getting into it. But I had a fantastic family practice physician in the small town where I grew up. I was able to work with her over the summer and shadow her, and that was really incredible. Even though I decided not to go into that field of medicine, just seeing how she worked with patients, how she spoke to people, how she cared for people, that was really inspiring to me. In terms of other support, later, once I got into things, I met my husband at the end of my third year of medical school. We got married after my intern year, I think. And so he's been an incredible support. I couldn't do what I do without him. He's a stay-at-home dad. He takes care of our 3 kids. He runs our household. Without that, I mean, I guess I'd have to hire a nanny or something to live in our house, but no, I couldn't do it without him, absolutely. And then of course, parents were absolutely supportive and instrumental in me being able to power through, because it's hard. It's a really hard course to take.
What do you do if someone will not accept help and take care of their unborn baby?
I mean, honestly, that goes to social work. We have a fantastic social work team at the hospital, and they will help out. It depends on like where we are in the process, right? If they're at the hospital, social work is absolutely available. If it's somebody who comes into the office and they've already been home with their baby and they're expressing difficulty, then there's a lot of different resources. Our staff at my office is trained to have resources available, both like CPS, which is I don't want to say punitive, but a little bit more like we're concerned that the baby's in danger. So we have CPS that we can refer to, but there's also a lot of resources for help with mental health, with, affording food, with housing, with, parenting classes, because it turns out nobody actually knows how to be a parent innately. It's things you have to learn. So yeah, we've got a lot of resources available, which is wonderful.
What is one case that stuck with you, good or bad?
Oh, I have so many cases that have stuck with me. This past year, we had a wonderful patient having her 3rd baby, I think. And the week before her scheduled delivery, she went to the office and we found that there was no heartbeat for the baby. And that's been weighing heavily on me, because I think y'all are young, but when you have children, I think it brings a whole new level of understanding to the grief and the horror of having to say goodbye to a child. So that's a rough case that has stuck with me, and that's recent-ish, but it's been a few months, and it's heavy on my mind nearly every day.
How can I prepare for this career?
That's a big old question. That's a big old question. How can you prepare for this career? I don't think you can, my friend. It's hard. It's you go through it. You go through the medical school and the residency that you want to do, and I think a lot of it you learn as you go. Like I said, having good support network, taking care of yourself and making sure that there are other parts to you as a human than just being a doctor, is really important, and will serve you being a doctor as well. If you can travel, if you can learn more about other cultures, languages, about other people, about literature, about the arts, whatever it is that you want to learn, that will only make you better at taking care of your patients. It's a very general answer to a very big question.
What other kinds of doctors do you work with?
Yeah, so we work with a lot of types of doctors because I take care of half the population. And so even though I do OB/GYN, I take care of specifically female health issues, women still have hearts and brains and lungs and joints and all of that. So we work with a lot of other specialties. We work more closely with GYN oncology is a specialty there. They do OB/GYN residency for 4 years, and then they do fellowship to take care of female cancers. So we work closely with them. We work closely with maternal fetal medicine, which is they take care of high-risk pregnancies. We work fairly closely with general surgery because we do surgery and they do surgery. And sometimes we go looking for an ovarian cyst and find appendicitis. And sometimes they go looking for appendicitis and find endometriosis. So we work fairly closely with general surgery. In the hospital, pregnancy in general, it turns out pregnancy is very dangerous for people. Humans did not evolve well to have babies. So most of the time, deliveries are absolutely fine and there's no major problems, but things can go very bad very quickly. So we do end up working, not terribly uncommonly, with ICU specialists or with trauma surgeons when we have massive hemorrhages or things like that going on, that we just need a little extra help with taking care of people. But yeah, I mean, we can work with just about anybody because our patients have all the other parts too.
I missed one here in the chat. During the process of becoming a doctor, do you recommend having children during medical school, residency, or once you have start to build a career, especially due to political situations that may affect women's career in the future?
That's a really hard question. It will come down to just what personally works for you. I have 3 children. I will say there's not a good time to have a child. It's always going to be hard. It's always going to be not ideal time to have a child if you are also planning on practicing medicine. I chose to have children at the end of my residency, is when I had my first child as a chief resident. I had my second year into my private practice, and then decided to have a third, and that was, well, she just turned 7, so I guess 7 years ago. I know that there are many doctors that choose to have children in college or in medical school. There are many doctors that choose to wait until they're out of residency and then start. I think each time is going to bring its own challenges, and trying to figure out how to navigate parenthood and physicianhood. It's never going to be easy. So it's ends up being a very personal decision on what works best for you, but there's not a great time to do it.
Let's see. I'm interested in becoming an OB/GYN, but I'm scared of failing in the sense that something might go wrong, or what if I make the wrong call? Do you have any advice for me?
I think if you are afraid that something's going to go wrong, that makes you a good doctor. If you don't have that thought always in the back of your mind, then you're probably not in medicine for the right reason. I don't know how to fix that. I'm scared all the time that something will happen. And that's probably the hardest part of my job, is that if I mess up, something very bad could happen. And that can be really stressful, but it's also exceptionally rewarding. And it's an honor that I get to help people through hard times and hard things. I don't know that I have advice. It's hard, it's scary. And I think you just have to be brave.
All right. All the questions I see in the chat. Does anyone else have any questions? All right. Okay. Well, thank you so much. This was great. I really appreciate you being on the call. Everyone, please say thank you to Dr. LaValley Willsey. And if we have any additional questions, I will share those with you.
Absolutely. Sounds good. And you can always email me as well via Sam if you have any specific other questions. This is a hard job, but it's exceptionally rewarding. I joke that I would love to work at Barnes & Noble and have no responsibility, but honestly, I don't know if I would be happy in any other career.
Oh, wonderful. Thank you so much. Enjoy the rest of your morning, and we really appreciate you being here.
Bye.
Our next speaker is Brittany Bartolome. She completed her Bachelor of Arts at UC Berkeley and then completed her medical school training at University of Nevada. She went on to complete her residency in internal medicine at UC Davis Medical Center, where she continues to work as a hospitalist. Her career interests include hospital medicine and rehabilitation. So welcome, Dr. Bartolome.
Thanks, Sam. Hi, everybody. Thank you for the intro. So let's get started. I prepared a kind of like a presentation about what my job entails and kind of the steps to getting into medicine, specifically being a doctor. And then I'll leave it open for some Q&A towards the end. I'll try to do a good job of checking the chat, but if you guys have any questions that pop up, either, I guess you could like raise your hand or maybe Sam could kind of prompt me if there is a question in the chat. I'm happy to like kind of pause the presentation anytime. All right, so I'm going to share my screen. And then I think you guys can see it okay. All right, so getting started.
Perfect, we can see it.
Perfect. Okay. So, kind of what I'm going to talk about is just a brief overview of what I do. I'm a hospitalist, a little bit about me, how I got here, and then how this all pertains to you guys and whether or not this is a right career for you, if medicine is even something you're interested in, and then some Q&A like I mentioned. So what is hospital medicine? It is a specialty of internal medicine, but it could be family medicine as well. What I do is I work strictly in the hospital. So we call that inpatient versus outpatient is like your primary care doctor. So this means that I'm working kind of like a shift work. It's not a Monday to Friday job from 8 to 5. It's kind of a pre-designated number of days and it's continuous. So sometimes I'll work 7 days in a row. That's pretty standard. And kind of what we do is our patients, rotate through. As if you guys have ever been hospitalized before, you go into the emergency department and then someone decides that you need to be admitted to the hospital. And that's when that's when you are assumed, your care is assumed by a physician, and that physician is me. And so I would take care of you throughout your entire stay at the hospital, at least for as long as my shift is, whether that's days, sometimes weeks, or just a couple of days. And then I hand off to the other provider, assuming you're still in the hospital. But basically, that's what a hospitalist is. We're just working with patients who have been admitted to the hospital. We basically try to get you better and out the door and back home. And then your primary care doctor is somebody who would kind of follow you more longitudinally. So the question I commonly get asked by patients in the hospital is, oh, do you have a clinic? The answer is no, I do not. We're very different than primary care doctors. Our training is similar, but what our specialty in is different in that, again, we're in the hospital. It's very hospital based. We don't have office hours. We don't see people in the clinic. So let's say I discharged you from the hospital, you wouldn't see me again. I am just there to get you better while you're in the hospital and out the door. And so my primary job is making sure I'm able to diagnose what your illness is, get you the right medications on a day-to-day, and develop and follow kind of a care plan that I've created, as well as working with other people in the hospital to basically get you home. So that's working with nursing staff, working with a dedicated case manager. Sometimes you need a physical therapist to see you. And so I coordinate your care in the hospital with all of these ancillary services to get you home. And like I mentioned before, we're not always internal medicine trained. People who do family medicine or pediatrics, sometimes other specialties, choose to work primarily in the hospital setting. And so they have this option to be like a pediatric hospitalist or a family medicine doctor who's also a hospitalist. They're a little bit different because family medicine is mostly outpatient, but some family medicine doctors are kind of shifting into like a half-half hospitalist, half primary care. And that's kind of what people used to do back in the day, where you have your primary care doctor that you see all the time. And let's say you get admitted to the hospital, then that doctor will follow you and see you in the hospital as well. And then they'll see you back in your clinic. I will say that I think that's kind of running out of favor now, just because the hours are pretty tough to be able to be jumping between clinic and in the hospital. And so that's kind of why we've segregated into hospital medicine and primary care medicine. And so a typical day in the life of a hospitalist is we usually get in around 7:30 in the morning. That's around the time I get in every day. And then we pre-chart. And that's really where I'm just sitting at a computer. I'm going over who my patients are for the day. It's usually the same patients I'll be seeing for the week. Sometimes they add a new patient who got admitted the night before. I take a look at all their notes, all their lab work, all their vital signs, and then I start kind of having a mental list of like, okay, this person's coming in for pneumonia. Like are they on the right antibiotics? Do I need to get any other specialty on board for this? Does it look like they need oxygen? And I develop their plan for the day. By around 9 o'clock, I'm done pre-charting. I'm done being at the computer. I'm ready to actually go see my patients. And that's called rounding. So sometimes you'll see on the TV shows like doctors are rounding. That's what rounding is. For my particular job, I have a cap of 13 patients a day. So sometimes it's less. Sometimes I'm seeing only 8 patients a day, but 13 is the absolute max. And those are 13 people that I will kind of go from room to room to room, see each patient, do a physical exam, kind of talk to them about their care plan and say like, okay, well, it looks like you're not feeling that much better today. Let's change direction. Or, oh, you look great. Maybe we can plan to discharge you later today, or maybe we can discharge you tomorrow. By 11 o'clock, I'm then meeting with the interdisciplinary or ancillary services. So that's like the nurse who's taking care of you, or the case manager who's assigned to your care, or a pharmacist. Sometimes people need social workers or a dietitian. I work with them around 11 o'clock. We all meet together in a huddle and say like, okay, here's a list of patients we're going to go through. This is the big plan for the day. Does anybody have any questions? And I'm usually the one leading it. So it's like, okay, Mr. Jones is here for pneumonia. It sounds like he has a new oxygen requirement, meaning he's needing oxygen to like breathe. He might need oxygen to go home with. Can we set him up with oxygen for home? That's where these services, like the nurse will try to see if they're able to take Mr. Jones off oxygen. My case manager will try to get him set up with oxygen so he can go home with it. And then our physical and occupational therapist will try to work with Mr. Jones to see like, well, is he even walking up and moving around? Does he need more help? And that's so that if there's any change to what you'd be like from what you were before the hospital to after the hospital, that's taken care of by us. So that we identify what your new issues are and if you need extra help for when you go home. Then around 12 o'clock is my lunch break. And, I call it's kind of like a fake break. It's kind of whether or not I want to take a break because essentially after that huddle, I'm just working on putting new orders in, making sure my documentation is up to date, go to more meetings. And that's pretty much it. That's my day. So in my mind, like my active hours are from 7:30 to 12, and then from 12 to whenever I finish all my notes and my orders. That's just really me sitting at a computer and making sure everything's documented, and then I can go home. Sometimes I can do my notes from home. That's the other nice thing is because everything we document is electronically. It's through our electronic medical record. There is some flexibility with when I can go home if I wanted to. So here's a sample actual schedule that I have this coming July and August. So everything in yellow, that's my assigned days. That's an example schedule of like what I have. And something I forgot to mention is, like how many days do you work a year? A hospitalist can work, some hospitals are like, you work 3 days in a row, 1 week, and then the next week you work 4 days in a row. As you guys can see kind of here in July, I'm doing that. And then this particular week right here, I'm just on backup, meaning I'm not actually working. I'm just there if somebody calls out sick. I'll potentially get called in during that week. And then you see here that I have kind of like this 7-day stretch. But in total, for my particular job at UC Davis, I only work 182 shifts a year. So that's kind of like half the year, if you guys think about it. That's pretty much it. I don't get a nice Monday to Friday, meaning like I wouldn't get weekends off, but I can get weeks off. So you can guys see here in August, like I'm going to go to Africa, right? I'm going to be there for about 2 or 3 weeks. And so there's a lot of flexibility with how I do my schedule. I can also kind of shift things around. So like, if my in-laws want to go to Tahoe for a weekend, I can always ask to have that off. And so I would say that's one of the biggest highlights of being a hospitalist is you get to be a doctor. You get to do kind of your specialty, but you also have a lot of flexibility with your scheduling. And that's something that really sets our particular job apart from like primary care, where you're kind of dedicated Monday to Friday. You have your weekends, but you're almost working every week of the year. Sometimes they work actually more shifts than a hospitalist. And that's just partly because we're in the hospital longer sometimes than a primary care doctor who's there from like 8 a.m., maybe sometimes 9 a.m. until 4 or 5. We're expected to be there earlier, like 7:30, and then we're expected to be kind of available until 6, just in case something happens to our patient, because these patients that we take care of are more sick than people who are in the clinic. So a little bit about me and kind of how I got here. I am a first-generation American. My parents are from the Philippines. I have 2 younger sisters. They actually decided to be a dentist and a PA, which is a physician assistant or physician associate now. A question I get asked is, did I know I always wanted to become a doctor? And my answer is actually yes. I knew specifically I did not want to be a dentist, a pharmacist, a nurse, a therapist. Like I didn't want to do any of that. And I would say that's just because during my time, if people were going to go into healthcare, it was either nurse or doctor. But I think nowadays, nurse, doctor, or dentist, I should say. But I think I knew I wanted to kind of lead a group. That was kind of more my vibe. I liked being in control. I liked making difficult decisions. I was very comfortable with stressful situations. I'm the oldest of 3 kids, so it was like a common practice for me. It didn't really I wasn't scared of the prospect of being a doctor. And yes, admittedly, my parents also wanted me to be a doctor, so I got a lot of support for this. My path to medicine. So after high school, I went to UC Berkeley. I went out of state, so I'm actually originally from Las Vegas. Applied out of state and in state, and I got into Cal. So I was there for 4 years, graduated with honors. I worked really hard. That was kind of the toughest years, I would say, because I was really kind of ramping up my CV, working on research presentations, publications, getting a good GPA. You also have to volunteer. You also have to shadow. And this is because I knew I wanted to go into medicine. Wherever college you go to, it doesn't actually matter what your college is, but if you already have a thought that you want to go into healthcare, it's good to kind of get that ball rolling and start finding advisors when you go to college, because they're going to kind of set you up with, here are the resources that you need to know, here's the type of volunteering you should do, here are research projects you can work on. I decided to take a gap year after college. I didn't feel like my CV was fully robust enough to apply to med school right away, because the med school application process happens during your senior year of college if you want to matriculate the following year. So let's say you're in your senior year of college, you graduate in the spring, and your plan is to start medical school right away. You would have to submit your application and start your interviews during the fall of your senior year, which I felt like was a lot. So that's why I opted to do a gap year. I wanted to get a job, like a real girl job. I wanted to work on my applications more. I also wanted to make money because applications are expensive. And so I took a gap year, and that's pretty typical nowadays, people taking a year, 2 years, sometimes 3 or more off to kind of work on their CV in preparation for medical school. So got into med school, went back to Nevada, worked there. I was there for 4 years. That's the typical number of years you're in medical school. And then the application cycle starts again. I applied for residency, went back to California, did my residency at UC Davis for about 3 years. So in total, my path to medicine took about 12 years of training. But now I'm going to go into what the typical path to medicine looks like. And some factors to consider is, I boiled it down to like 3 things. Learning pace, kind of knowing where you're at. If you feel like you're an average student, or sometimes you take more time to understand subjects, keep that in mind, just because the path to medicine is very rigorous and you're competing with people who are the top of their class from high school and the top of their class in college. Understand that you're going to be doing a lot of examinations, and you need to pass these exams to kind of move on to the next step. And they're very essential, and also kind of guides where you're going to go for residency, what kind of specialty you end up doing. Understand that you have a lot of prerequisites that you need to do. So if you're when you guys go to college, knowing that if you're going to go to medical school, you need so many years of biology, chemistry, OChem, math, and English, like under your belt before you even consider applying. And those are the standard prerequisites, in addition to the exams that you're going to take. Here's a timeline overview just to kind of give you a sense of, what does this look like? What does it look like to get to where I'm at now? And where I'm at right now is kind of here at the end. College, doing your pre-med courses, trying to get a competitive GPA, and that's like a GPA over 3.65. And then when you start prepping for medical school, again, this can kind of depend on when you want to apply. But these are the things you need to work on: letters of rec, getting your bachelor's, doing the MCAT, making a personal statement, making sure you're doing volunteer and extracurriculars. And knowing that the MCAT is going to fall between the months of January to September. People spend months just studying for the MCAT alone. And so for me, doing that while also studying in college was just a lot. And that's why I really took my time with that gap year. And then just know the timeline of when med school applications start, when you start doing your interviews, and when you start getting your acceptances. So whether you want this to fall in your last year of college, it takes some insight. You have to kind of think ahead. Is this something you want to commit to during college, or do you want to push it off by a year? And then knowing that when you start medical school, again, it's another 4 years of doing your pre-clinicals. That's like being in the classroom for 2 years and learning everything you need to know about being a doctor. And then in your last 2 years, you're in the hospital already, and you're a medical student, and you're rotating on different specialties. You're being asked to create diagnoses for patients. So medical school really is like, you get 2 years to learn everything. And then in your last 2 years, you're in the hospital and you're being asked to diagnose patients all of a sudden and come up with therapies and treatment plans. That's why it's so rigorous. That's why it's so difficult to get into medical school, is because it's just 4 years to learn all that on how to be a doctor is not a lot of time. So it's very fast, and you are taking your board exams. The USMLE are divided into 3 steps. It's step 1, step 2, and step 3. Step 1 and 2 you take during medical school, and they're very hard exams. They're about an 8 to 9 hour exam just sitting. If you think the SATs are long, the USMLE is a lot longer. You are spending the whole day there. You're getting there at 8 in the morning. You're not leaving till 5 p.m. And it's cramming every piece of medical knowledge into this 8-hour exam with breaks. And then the part that is incredibly stressful about the USMLE is it's a one-time test. So it's not like the SAT where you take it once and then you can get a better score. It's you take it once, and either you pass or you fail. And if you pass, then great. But I will say that schools are looking at how high you scored to determine what specialty you want to go to. So specialties like orthopedic surgery, neurosurgery, any kind of surgery, radiology, dermatology, ophthalmology, those are classically competitive. And so they're going to want much higher scores. And again, you're competing with the entire country on being in the top 20%. If you're going into something like what I'm going into, which is internal medicine, it's less competitive because they need more of those doctors. And so there's a wider spectrum of scores that they'll accept. Obviously, the more competitive your score, the better your residency is, or the more competitive your residency is. So if you had this vision that you wanted to go to Duke or Harvard for residency, just know that you have to have some of the top scores to get in. And during medical school, it's kind of a repeat. You start applying for residency, you do your interviews, and then that boils down to the match day. Applying for residency is different than medical school because, again, one, you're competing with medical students. You're already competing with the cream of the crop, but they're also kind of pitting you against each other. They're looking at your board scores, how strong your letters of rec are, how well you did on your clerkship. So when you're rotating in the hospital, your doctors who are supervising you are grading you guys. Did you get honors, or were you considered an average student? And it's all subjective, right? And submitting all that information and asking these residencies to take you. Now, it's not like medical school where you can get accepted to 5 or 10 medical schools and you get to pick. Residency has a computer algorithm where they will match you with another residency program. So on match day, you actually only find out the one place you're going to. You don't have a choice. So it's like, hey, you interviewed at 10 places. You said you send a rank list to kind of the ether of residencies, and the residencies will also rank you compared to all the other interview or applicants. And this algorithm, this computer algorithm basically matches you. So you say like, my top school is UC Davis, and then my second school is USC. But let's say USC thought you were their best one. So it's very possible that that's the highest match and you end up going to USC. Sometimes people find out that they have to go lower on their rank list and they're only getting to their number 10 spot. It really depends on how the residency feels, about you. And some people actually don't even match. So they go through all this medical school training and they find out on match day they don't actually match anywhere. And so what does that mean? It means they are kind of in a limbo period where they have to scramble and find a residency that will take them. Sometimes the residency is not even in their own specialty. Sometimes it's, I applied to be an anesthesiologist and I didn't match, and now I have nowhere to go for residency. And you'll hear about some OB-GYN residency that has an opening in middle of Missouri. And at that point, you're making a difficult decision. Do I go to Missouri and become an OB-GYN and give up my dreams of becoming an anesthesiologist, or do I just start all over again? And it's a very difficult decision, and it all happens in March. And soon, by 3 or 4 months later, you're starting your residency, and it's kind of this whole process again. Like, you do your residency, and then what? Do I want to do fellowship, or do I want to go straight into my real job? So I'll go into a little bit of that later, but you can see it's kind of this very big process of all the things that you need to do and how long it takes. So going to med school prereqs, we kind of talked about a little bit about it. A strong GP, obviously you have to graduate, you do your pre-med courses, doing the MCAT, making sure you get a competitive score, getting strong letters, and a lot of longitudinal activities. When I was in medical school, I was really focused on kind of making sure I got good grades, but that wasn't enough. I needed to do volunteering and extracurriculars. As I mentioned with medical school, it's divided into the first 2 years and the last 2 years. Preclinical is all that school. It's a lot like college. You do exams all the time. And then your last 2 years are you go through your clerkships, internal medicine, surgery, family medicine, and you decide at this point in time, like, what is the specialty I want to do? You apply, you match, and then you go into your specialty, your residency. I'm not going to spend too much time about residency, but basically you're a doctor, you're doing your specialty, and you're working even harder. Specialty length varies across like what you want to do. Internal medicine, which is what I did, was only 3 years, which is nice. Surgical specialties can range from 4 to 7 years. So let's say you want to be a neurosurgeon, you're going to be in residency for 7 years. And the other thing to note with residency is just because you're a doctor, you're actually not getting paid doctor's salary. You're getting paid below the minimum wage. You're making very little money, and you're working in like maybe 80 to 100 hours a week to take care of patients. And that's why it's so grueling, and people have to really think about like what they want to do. So it's tough. You don't get a lot of time off either. I think I got 4 days off a month as a resident, and that's internal medicine. It's worse if you're a surgeon. And then after residency, you can start your real job, which is what I did. I said, I'm not going to do a fellowship. I don't want to specialize even more. And I just did my board exams, and then I finished. My husband, on the other hand, he applied to a sports medicine fellowship. So he did 4 years of PM&R, physical medicine and rehab, and then he did another year of fellowship in New York. So looking at 11 to 16 years of total training from college to completion. So pros and cons. I'll talk about the good stuff. I've mentioned this, like, the nice thing is the scheduling. It's very challenging, but there is a component of teamwork. It's a decent income, and I get to, it's always changing, so I never really get bored. The cons I don't really have to go into a whole lot. It's very clear that it's a lot of training. You're expected to lead. Lawsuits, medical school debt, they're real. Patients are challenging. It can be very stressful. It can be very costly, and it can be very overwhelming. Things I wish I knew before. So know that you're taking a lot of tests. You're going to be doing a lot of spending a lot of time on paperwork. You'll be burnt out. Sometimes you'll get jaded. You're competing all the time with your classmates, and you get to see kind of your friends from high school grow up and live their lives. I had friends who were already buying houses, having families, and I was still in medical school. And I'm like, I don't have a family. I don't have kids. I can't afford a house. Like, why am I doing this? So these are some things that I wish I knew beforehand. But for me, at the end of the day, I would say that, why I get up in the morning, it's very fulfilling. During COVID, I felt needed because I was on the front lines. I like being able to explain something difficult in simple terms to my patients. I never get bored. And just being an example, I really enjoy what I do. The training to get here was tough, but it doesn't feel like work at the end of the day. Um, Silver lining, I definitely found a passion in my career. Like I mentioned, the sense of purpose, especially during the pandemic. I still get to live the dream that I envisioned for myself. It was just a bit later. It's something that you kind of have to think about. And I still make time for family and travel. These are all the kind of photos that I was able to do, after all my training was done. I met my husband. I was training for a half marathon during residency. I got married. I'm now able to take my mom on vacations abroad. It's like the little things that, it made it all worth it at the end. So choosing what's best for you, asking yourself, like, why do you want to be a doctor if that's something you think you want to do? I kind of hear like, well, you help people. Yeah, but you can help people doing a lot of other things. Social workers help people too. Oh, it pays well. That's not true. I don't think that this job pays particularly well, especially when there's tech out there, tech jobs, marketing, any kind of business job, you'll make a lot more money. So this isn't the reason to do it. Um, it's a safe job. That's not true. We get a lot of patients who are not the safest, or sometimes you get told that there's a bomb threat. It's not COVID, right? It's not a safe job. Don't think you get recognized, because I don't get recognized on the day-to-day by my patients. And so that's not why I do this. Definitely don't do it because it makes your parents happy. um, so my advice is know what you want to do before taking the leap. Make sure you're thinking about your mental health. Um, Anyone can do this. It's a lot of self-discipline. You don't have to be the smartest person in the room. You just have to be willing to put in the time and effort. So always ask yourself, is it really worth it? If you feel like you need to rush it, you might not want it enough. And that goes for people who want to go straight into medical school after college. If you don't want to be a doctor, but you want to go into healthcare too, so what do you do now? Be proactive. Look at other career options. Shadow, volunteer. Ask yourself, why do I want to be a doctor and not a nurse or a pharmacist? Take your time thinking about it, but don't take too much time, just because no matter what you do in healthcare, you do have to put in a level of preparation, prerequisites, board exams, regardless. It may not be as long as medical school, but there is some time. If your parents are involved with your decision making, involve them early. Be transparent about your feelings and concerns. This was actually an approach my sisters took. My parents were trying to get them to be doctors, but they were like, no, I would be much happier if I did something else. And so other rewarding healthcare careers, there's physician assistants, there's RNs, therapists, optometrists, psychologists. You could be a nurse practitioner. You can go into dentistry. These are actually my cousins, or my sisters and my cousins. And so this is kind of the approach that they took instead of becoming a doctor, and they're very happy. And this is kind of what I mentioned before: shadow, volunteer early, find a mentor if you can. Know what it is you want to do and be prepared to do, be prepared for what it takes to get there. Be proactive, find a mentor, volunteer, shadow as much as you can, and start early. Okay, I'm sorry, I totally rushed that. It was kind of a lot of information, and I know that's like all 30 minutes, but if you guys have any questions, you can always email me. I'll leave my email for Sam for her to share for you guys.
Thank you so much. This is great. This gave a great overview. We really appreciate you being here.
You're welcome.
Perfect. Well, thank you so much. We really appreciate it. And yeah, this gave us a great overview of your profession and of becoming a doctor in general. So thank you very, very much.
You're welcome. I'll leave my email here in case anybody has questions.
Okay.
I know it's a lot of information though.
No, it's great.
Okay. Thanks, guys.
Perfect. Well, thank you for being on. Enjoy the rest of your morning.
You too. Bye.
Thank you. All right. We're going to move into our next speaker. So up next is Dr. Guilfoy. Dr. Guilfoy is an orthopedic surgeon in Folsom since 1992. He is the medical director of the Folsom Surgery Center, and he is also the board chairman for the West Coast Spine and Joint Center in El Dorado Hills. So welcome, Dr. Guilfoy.
All right. Well, hi, everybody. I'm Dr. Guilfoy. I've been in Folsom since 1992. I've been an orthopedic surgeon since 1990. I've performed somewhere around 15,000 surgeries since I've been in Folsom, quite active, and I've seen probably at least 2 to 3 times that many patients and treated them, a lot of them non-operatively. So that's my general background. I served 13 years in the Air Force prior to coming to Folsom, and we'll kind of go through that a little bit here. So what is an orthopedic surgeon? No, I don't straighten teeth. That's an orthodontist. I fix bones. In this case, I'm going to be showing you a lot of x-rays, kind of what I do, the kinds of things that I'll fix, some of the practicalities that I have in general. I'm also going to be throwing in how I got here, what helped me to my decision of orthopedics as a specialty, what I do in orthopedics, what choices you have, and then give you some advice on how to get there, the ups and downs of medicine. So in orthopedics, I fix bones. This gentleman was a motocross rider out at Prairie City. And he hit a big jump, came down, drove his ankle up through his tibia bone right here. Required pretty extensive surgeries on it. And he's been my patient now for well over 20 years for other various problems along with his family. So an orthopedic surgeon, basically, I treat the musculoskeletal system. Bones, joints, and muscles, trauma injuries that occur along the way, sports injuries, simple home injuries, dog injuries from leashes getting entangled, basically all things as pertains to the musculoskeletal. So I'm going to be showing you slides of the things I do, things that that come across. I'll keep away from the some of the bloody gory ones, but just give you a general idea of what a general orthopedist does. When I started in Folsom, I saw pretty much everything orthopedically. As the city's grown around, there's been some more subspecialties. I kind of am not doing as much hand or foot as I did in the past. I do more total joints now. I still do some trauma, although I don't cover the emergency room as much. The thing with orthopedics is when you're on call for the emergency room, there are things you have to go into. There's a little bit more demand in that. The call can be somewhat grueling. It can be weekends, it can be evenings, it can be holidays. This particular slide is from a young lady that fell at Skateland, broke both wrists. This is the left wrist. You see the fracture right here. It's off. It's what's called comminuted, broken into multiple pieces. This required surgery, as seen on the other slide here, with a plate and screws. Fortunately, her other side was minimally fractured, so we could keep her in a splint. It can be quite debilitating to have both wrists splinted. This young man here came off his bicycle, mountain bike, crashed. This is a clavicle fracture, multiple screws, plate. Fixing it, he had some joining rib fractures, which are hard to see on the x-ray, fracture in here and here. And the splinting with the plate assists in position of his arm, and his functioning. He's doing quite well. I also do arthroscopy, which is sports medicine, looking in the joints, shoulders, hips, knees, ankles, through small incisions. For the shoulder, I do rotator cuff repairs. I do dislocation repairs. The knee, this is a knee here of a young soccer player. I do ligament repairs. This is a meniscus back here. I repair the meniscus. This is a ligament in the center of the knee called a posterior cruciate. Her anterior cruciate should go this way. That's gone. This is a replacement. So I do grafts and reconstructions, soft tissue injuries. So how did I get there? Going to college, I really didn't know my direction. It's difficult to know when you get started exactly what you want to do. It's important to try and develop that, what fits your personality. I didn't know my direction. I eventually went to a physical science major. So I had some math, science, and chemistry, things that I was interested in. I thought about graduate training, still didn't know where I was going to go, teaching, research, contracting. So what's the solution? I ran away to a small island in the Pacific with 6 other students. And this island is Majuro in the Marshall Islands. Small little area, about 3 square miles. Up in here, there's the small town. And we set about building a school, and we did cinder block. We built a school. We spent about 4 to 5 months there building the school. And during that time, it was interesting, a sailboat came into the port there, and the sailboat had a surgeon on it and his wife, who was a nurse, and it had a dentist on it, and his wife was a dental hygienist. And they came into town, and they did some procedures for the locals. They saw and treated people there for about 5 to 7 days, and then they sailed off. And I thought, oh, that's pretty cool. You can kind of call some things different ways with medicine, and it gives you a chance to really give back to a community, give back to people. So from there, I went back to school. I fortunately had done well in the sciences. I spent some extra time on the MCAT, and I was fortunate enough to apply to medical school and got accepted at Loma Linda in Southern California. During that time when I got accepted, I applied for a scholarship with the Air Force, and I was granted that, which was a big advantage for me. Because they paid for my medical school, all tuition. They paid for my books. They gave me a monthly stipend, and I had 4 years of medical school, and it was a 4-year commitment to give back. After I finished medical school, I still was not certain what was really getting me as far as a passion of what I wanted to do. And after 1 year of a rotating internship, which was a civilian in Salt Lake City, where I did some OB, I did some pediatrics, I delivered babies, I did some internal medicine, I did some emergency room, and I wasn't ready to commit yet. So I kind of took the long route getting here. What I did is I signed up as a general medical officer in the Air Force, and they sent me to West Germany for 3 years. And I had a great time in the Air Force. I saw families, I treated fractures, I did family practice, delivered some babies. Wasn't quite certain yet what I was going to do during a lot of that time, and somewhere near the end of that, I kind of realized I enjoyed treating fractures. It was mechanical. It hit me. I like to fix things, and orthopedics fits my personality. I get to see a problem, I get to treat it. I get to cut bones. I use saws. I use drills. I hit things with hammers. I can put hands on. Basically, when a patient comes in, my exams are all hands on. It kind of fits my personality. It's got its advantages and disadvantages, which we'll talk about down the road here. But it's also been a very rewarding lifestyle. So some of the things I fix is ankle fracture. This is called a trimalleolar fracture. There's a fracture on the inside. There's a fracture on the outside of the ankle. There's a fracture in the back of the ankle. I fix it with a plate and screws. Interesting story. Some of the skills you get as an orthopedic surgeon that are practical. I have a group of physicians, and we play music for charities and for Rotary. And we were on the coast in a small little town doing a charity fundraiser in a party. And we were on a break, and the party, they were having a limbo stick, and people were going around in the limbo stick, and a woman came by, and she probably had too much to drink, and she was having them lower it. She had these high heels on, and she had to go lower and lower, and she tried to jump over this thing, and she landed on the other side, about 6 feet away from me. I'm sitting at a table, and she completely dislocated her ankle and fractured. And so I'm looking at it going, well, I got to do something here. I got up, put it back into place, and we're in a very small area, on a remote area in the California coast. So EMTs aren't readily available right off. So I wrapped her up. We wrapped her up in lots of beach towels because it was a beach party. We put ice from the beer cooler around her ankle, and we took a Corona box and put it around the ankle, taped it up. When the paramedics finally get there, they realize their splints weren't as good as that splint, and that's how they transported her. The skills you get as an orthopedist is you get this hands-on experience that fortunately or unfortunately comes in handy at times when an emergency injury arises and you're there. This one here is a person training for the triathlon. He developed a stress fracture in his metatarsal here. He had a screw put into that. He also injured it in a motorcycle rally, and eventually had to have some reconstruction on his foot and ankle. Done quite well with it. Long rehabs on these kind of things. And you learn how to work with people in injuries, work them through injuries. It's a fibula fracture. This is down in the ankle. Multiple screws and plates on the side. This can be a simple injury of slipping off a curb or tripping or catching your cleat when you're sliding into second base. I replaced joints, shoulder joints that have worn out from chronic dislocations or chronic rotator cuff injuries. When they develop arthritis, there's no joint line. They get stiff, they get loosen up. We put a plate and screws and a ball and joint, and people can restore their function. They get rid of their pain. Hips that are destroyed. This gentleman couldn't hardly walk a foot. He was quite limited. He'd had ongoing arthritis here. We can replace their hip, and they can become quite mobile. You can see people start walking when they couldn't walk more than 10, 15 feet, and they can go out and walk unlimited. They can play golf again. They can restore a lot of functions that they can go on daily living without persistent pain. So what do I see daily in the orthopedic office? I see a lot of injuries, fractures, falls, crashes. I see bicycle injuries, motorcycle injuries. I see injuries from dancers, football players, soccer, lacrosse. I see people launched from trampolines. I see the dog injuries when they get run into in the dog park by a big dog. see horse injuries when people are bucked off. I see home injuries from falls on the ladder. The day in an orthopedic office can be really quite varied, especially if you are taking any kind of a trauma call with it. It can be very. I also see injuries from ligament injuries in the knee, shoulder injuries, and then worn out joints. Some of the fun things of orthopedics is I get to hear great stories. I hear the kid dumb stories. Like, you thought that was a good idea, huh? Okay. So I see the cheerleaders with the hip injuries and the ankle injuries. I see soccer players, their knee injuries, their hip injuries. For the first 12 years or so, when I was in Folsom, I was the team doctor for Folsom Bulldogs. I covered the football games. There were a number of times I came out on the field and reduced a fracture, put it back into place on the field. There are a number of times that I sent some of them to the emergency room, met them later, had to operate on them. But working with on the field, working with the sports injuries, it's a lot of fun. If that's your interest, that's something you can do in orthopedics. I see motorcycle riders. This gentleman was on his motorcycle on the track, fell, lost it, 90 miles an hour on the curve, had a plate and screws placed in it. This is a scapula fracture. He took the shoulder, put it through the scapula. This is the fracture fragments. Eventually had a plate and screws placed in it. This is from the side view underneath, looking at the plate and screws. I get to treat kids. I see them for injuries or sprains, mostly fractures. This was a youngster. She was on one of the electric scooters, kind of lost it, came down, broke her wrist. She's placed in a cast. About 6 weeks, she'll be out of that cast and start moving that wrist, and she's going to do quite well with that. I get to treat older seniors. This can be very rewarding. As I said before, I can have somebody with a hip that is degenerated, lost the joint line, severe amount of wear, and pain every day, and I can replace their hip, and they can go home the same day after replacing the hip, taking the ball side off, placing a titanium stem and a ceramic head, and a titanium cup. And they can begin walking that day. I replace their knees from wear and tear. And these are very rewarding, that I can see their life change when they've had pain in those joints for a number of years and they limit their activities, and I can restore their function and get them moving again. So one of the most interesting things I've seen in my medical career, well, as I mentioned, I see quite a varied group of things in my office, and each week's a little different. Every fracture is a little different. However, the most interesting things I've seen is doing some volunteer work. I've done medical trips to Honduras, Nicaragua, Haiti. I've worked on the Mexico border. I've seen congenital deformities that we don't see here in the United States because we have medical treatment, and people bring their kids in when there's some kind of a deformity, and we can correct those early. But I've seen kids walking. They've traveled 200-300 miles on a foot. They're 18 years old and their foot is turned 180 degrees and they walk on the side of it from a chronic club foot. I see untreated fractures that have been broken for sometimes years that need treatment. I see diseases that we don't usually see in the United States. I was in Haiti, and we came in right in the middle of a cholera outbreak, and I've never experienced that. It It was rewarding, but it was also exceedingly draining. And that's kind of the whole way through medicine and orthopedics. There's some exceedingly rewarding things out of it, but it can be draining at times. And you got to learn how to work that, and your free time, you have to use your free time, develop other interests, because it can be quite consuming. There's a total hip dislocation. If they didn't quite follow directions or had a fall post-operatively, that joint's put back in. Metatarsal fracture from a basketball injury. This is the patella fracture that slipped on the ice. And I love this picture because I think this is the coolest plate I use. I think it's such a darn cool looking thing. So what can you do with orthopedic training? Well, it's a long process getting there. And then on top of that, a subspecialty, maybe another 1 to 2 years. You can subspecialize in trauma, work in the emergency rooms, fractures, gunshots, car accidents. You can specialize in sports medicine. You can work the sports teams. You can work the young kids. You can work the pro football players. You have a number of different choices to go with there. Pediatrics, it's a subspecialty for the kids' congenital injuries or other specific problems that happen unique to pediatrics. You can treat the geriatric, the older folks, the total joints. You can specialize in spine. You can specialize in bone cancer or oncology. A lot of choices after you've already been through the orthopedic training. What are the tough parts of going into medicine? Well, number one, it is long hours. A lot of long training time. Surgery is even more requirement of time. There's no set schedule with that. It can happen at any time. The call can be very difficult because you're going to be on weekends or holidays because unfortunately injuries happen then. So once again, you've got to have some outlet. You've got to be able to balance that some with time off. You have to take some time for yourself because once it can be very, very all-consuming. Paperwork and charting, for me, that's really difficult because I haven't been growing up with computers, and now it's a lot of computer work, a lot of time on a computer. What are the tough parts? Well, you have to work with people in their most difficult times. I have people coming in, they've been hurt. They come to my office, they've been through the emergency room, they've had some delays getting there, and they've been hurt for a long time. Those are the tough parts. Orthopedic training, you're going to go to college, you're going to go to an internship for a year, orthopedics for another 4 years. Some programs are requiring an extra year of research. Then if you go into specialty, you may have another 1 to 2 years after that. So it takes something special to get there. This was an interesting, a little bit different that came in. This is a shoulder fracture up in the upper left-hand corner. She fell in Mexico. She had it fixed down there in severe pain. The fixation is a little more unusual. We don't use these in these days, but it was about 4 or 5 years ago. She came back up here and started following with me. She lives in the area. Over the course of about 4 or 5 months, the fracture began to fail. The fixation failed. You can see the screws start to penetrate into the joint. She eventually required a shoulder replacement. Had some trouble with that and actually had to have a revision of that to another shoulder. This was about 4 or 5 years ago. She's done well since then. And then she came into my office with a unique problem a couple of months ago. Anybody know what this is? This little violin on the back, that identifies as a brown recluse spider. And a brown recluse spider, when they bite, they're very rare in California, but when they bite, their venom isn't so much a systemic toxin, it's a local. It starts to dissolve muscles. And she came in because we'd treated her for so long with the bite. And this is a couple of bites that didn't envenomate. And this one was an envenomation. This was a solid lump underneath here. So a little disclaimer, I think I said I wasn't going to show any blood guts. Well, I am. So if you're queasy at all, you can just close your eyes. But I opened this incision up right here. And basically the whole tissue underneath it was necrotic, dead. Basically took some time, had to clean out everything that it was dead. And this is all from that spider bite toxin. Cleaned up the tissues. Actually, I could close this up, and she's doing well with that. So what are the most positive parts of medicine, especially orthopedics? I get to work with people in the most difficult times. That's a hard top part, but then I help them get through it and return to full function. I get a tremendous amount of work satisfaction. I get to hear patients say when they've had difficult problems or they have a difficult surgery, I trust you. I get a lot of satisfaction and feedback from patients when I can get them up and I can get them walking again. So keep focused in a direction. My advice to you, you get into college, take a major that really interests you. You don't have to do biology. You can take something that you find an interest in and do well with it. Just make sure you know the basic classes that are required for medical school and do well with those. Be happy with your decision in college. Study well for the MCAT. But the other keys for medical school is be active in sports or be active in community service or have a specific personal accomplishment in music, the arts, do something outside of just college and grades. These are things that catch the eye of the admissions to medical school. They want to know that you're going to be able to withstand the demands of it by having other outside interests. For me, military sponsorship got me through medical school without debt. When I served my time with the military, I got out of, I separated from the military with no debt, which was very convenient in making my decision to go into a private practice. So success in medicine is a passion, commitment, and kind of a calling. It's not for money, glory. As the previous physician told you, it's not because your mom and dad want you to, or you think it sounds cool. It's something you want to do because it's demanding. It can take a lot out of you physically and emotionally, and you got to be able to have that balanced out. So, any questions at all?
Yeah, let's see. How do you deal with injuries in areas with smaller bones like the hand?
So smaller bones, we have different kits for different parts of the bodies. So in the operating room, they'll bring out the handset, which is a number of small little fracture plates and screws. Sometimes we're just fixing them with pins. And sometimes I'm working with glasses that actually have a little magnifier on it.
We have time for one more question. What are your pieces of advice for anyone who wishes to pursue this career, and why did you pursue it? I'm a huge fan of this career and want to pursue it as well.
As I said earlier, I really enjoyed fixing things. I really enjoy seeing a problem and addressing it right then and there. Orthopedics is about addressing a specific problem, whether it's a fracture or torn ligaments. And we can see people, we can treat them. For me now, I am seeing people that I saw 30, 40 years ago, and I'm treating their kids now. I also see people that I treated 30 or 40 years ago in their sports injuries, and now they're worn out and I'm replacing their joints. I have one family I've treated 4 generations of them. And so that's really it is about this specialty. is the mechanics of it, the ORs. I enjoy working with OR staff. It's a group that is very easy to be around, and I get to put my hands on things, drill bones, saw them, cut them.
All right. This is great. Thank you so much for sharing. I love seeing all the pictures. I know we got a little gory, but I think that's, if they want to be in healthcare, this is some of the stuff they're going to see.
I got a lot more.
Well,
Yeah.
I appreciate you being on so much. Thank you for sharing your morning with us and your career with us. We really appreciate it.
All right. Thank you.
All
You guys,
right.
good
Have a
luck to
good
you
rest of
all, and
yes.
decision, and take time and figure out who you are and what you want to do.
All right. Bye-bye now.
Bye-bye.
All right. We're going to jump into our last speaker for the day. So Dr. Aimee Sisson, she's a public health doctor who serves as the public health officer for Yolo County. So welcome, Dr. Sisson.
Thank you, Sam. It sounds like I am standing between you and the rest of your day, including lunch. So bear with me. Hopefully this will be enjoyable for you. I know it always is for me. As Sam said, I'm Dr. Aimee Sisson. I'm the health officer for Yolo County. If I'd asked, 6 years ago if anyone had heard of a health officer before, I think no one would raise their hands. I think if I asked the question now, having all been through the COVID-19 pandemic, just about all of you would raise your hands. So I think I have a little less explaining to do about what a health officer does, but let me start by telling you what I do, and then I'll talk a little bit about sort of my career path to get here, which I think one of the takeaways that I hope you get from my talk today is that your journey into your career may not be a straight line. We always think, okay, point A to point B, and you're going to just have this direct route, and it ends up being a whole lot like this. And sometimes you go backwards, and sometimes where you end up is not where you thought you would be, and it's all good because you're learning something along the way about yourself and helping people. So health officer, and more specifically, my specialty in medicine is preventive medicine, which is probably a specialty that you haven't heard of. It's actually a relatively small specialty. I didn't learn about it until I was already, I'd graduated from medical school and I was in a master's of public health program. But it is a specialty. It's general preventive medicine and public health, and it's exactly what it sounds like. We focus on prevention of disease and really trying to keep people from getting sick in the first place. We also look at detecting disease early with things like screening for cancer, for example. That's a type of prevention. And also, if people have a disease, trying to prevent them from developing complications. So if people have diabetes, if their blood sugars are high, over time, they will develop complications where they could lose their eyesight. They might need their limbs amputated. They could have their kidneys fail. And so people in preventive medicine also work on, trying to prevent those complications in people who already have disease. But the real focus, unsurprisingly, since it's called preventive medicine, is on prevention and trying to keep people healthy. As the health officer in Yolo County, I am sort of responsible for the health of everybody who lives in Yolo County. Most of you probably live in Sacramento County. Yolo County starts on the other side of the Sacramento River, so West Sacramento, if you were to drive across the Tower Bridge, or across Highway 50. Yolo County starts in West Sacramento. We have 4 cities. We have West Sacramento, Davis, Woodland, and Winters. And then a lot of farmland, which you can sort of see in this virtual background behind me. A lot of Yolo County is farmland, but there's about 225,000 people who live in Yolo County. Obviously, I don't see them all in a clinic every day. Unlike probably everyone else you've heard from in this series, and including the orthopedic surgeon, I think is what I caught the tail end of that. Very different type of practice, sitting in an office, seeing patients every 15 minutes, probably on a clinic day, and then going into the operating room and fixing things on an OR day. I don't have a clinic. I typically don't see patients directly, although I'm involved in patient care. I'm consulted on a lot of infectious disease cases, but I don't do direct patient care. I am instead thinking a lot about policy in terms of how we prevent disease, infectious diseases especially. But again, doing these clinical consults for some of our more unusual diseases of public health significance, such as tuberculosis. Also, you're probably hearing a lot about measles right now, and I'm heavily involved in that. Just let's see, 2 days ago, I was actually traveling. I was down in Pasadena in the airport, flying home from a work meeting, and received a call from a provider in an outpatient clinic with concerns that a child that they were taking care of might have measles. And so they described the patient to me, their symptoms, the timeline of those symptoms, whether, they had traveled anywhere recently, whether they were vaccinated, and we sort of made a decision together, like, okay, this sounds like it could be measles and you should get this patient tested. And the reason why they call me is because the test for measles, the fastest way to get results is to have it done at a public health lab, as opposed to sending it to like a Quest or your usual laboratory provider. Sometimes these are done within a health system. Sometimes they're sent to these commercial labs like Quest, which can take up to a week to get a measles test result. And our public health lab can usually get it the same day that they receive the specimen, if not the next day. And that allows us, because measles is so infectious, we want to know if somebody has it, because we all of a sudden need to start finding everyone around them who is potentially exposed to measles. Because the challenge with measles is that people are infectious before they develop, not before they feel sick. They become infectious right around when their symptoms start. But the initial symptoms of measles are pretty vague. It's things like a fever and maybe a cough, maybe a runny nose, maybe some redness in your eye or pink eye conjunctivitis. And it's not until about 4 days after that that you get a rash. That is when you can say that is measles. And so in those 4 days, people may go about their lives. They may go to the grocery store, they may go to school, they may go to work. And measles is the most infectious disease that we know about. The average person with measles spreads it to 16 or 18 other people. And so when we have somebody with measles, our public health team has to do a lot of what we call contact tracing, which you probably heard about during the pandemic, finding out who they were in contact with, where they went. And measles spreads through the air, and it can hang in the air for at least an hour after somebody leaves a space. So that means a lot of people potentially exposed. So what our team ends up doing is tracking them down, finding out who they are, and then whether they are protected from measles. There's a vaccine, the MMR vaccine, that can protect against measles. And so we do a lot of calling of these contacts to find out if they've been vaccinated against measles. And if they haven't, we try to bring them in quickly. We have a 72-hour window after they've been exposed to get them vaccinated. And then if we're beyond that and it's somebody who's at high risk, maybe they have HIV or they just had an organ transplant or they're getting chemotherapy for cancer, we have another option to protect them, which is something called immunoglobulin, which is basically an antibody infusion that we would give to someone after their exposure to prevent them from developing measles. So that's just one example that's not COVID of the work that we do in preventive medicine and public health, and that I do as a public health officer. Let me say a little bit more about my journey to become a health officer. And as I said, it's not a direct route. When I was probably junior high, maybe a little bit before that, I became interested in medicine. I liked science, but I also liked people, and medicine, becoming a doctor felt like an opportunity to get to do both of those things, to take care of people and to use my interest in science. I majored in biochemistry in college, and then applied to medical school, got in, went to UCLA down in Los Angeles, and I really loved medical school, especially the third and fourth year when you actually get to start taking care of patients. The first couple of years is a lot of, studying and book time, but finally having the chance to put it into practice and start seeing patients. And in your third and fourth year of medical school, you sort of rotate through various subject areas: surgery, medicine, or internal medicine, pediatrics, OBGYN. There's no rotation in public health, so I didn't get exposed to it, but I liked everything that I saw as a third and fourth year medical student. I had a really hard time deciding what kind of doctor I wanted to be. My joke when everyone asked me, what kind of doctor do you want to be when you grow up, I always said a good one, but I didn't know what my specialty. I liked surgery. I liked the idea of fixing people. I also really liked solving mysteries and puzzles, and to me that was sort of infectious disease and internal medicine. And so I ended up, I really liked surgery. I liked the idea of fixing things. So I started out in a surgery residency program, and I did that for about a year and realized that I liked it, but I didn't love it. And I was working 80 to 100 hours a week, not sleeping a whole lot. I became a much grumpier version of myself. And I recognized that that wasn't what I wanted to do for the rest of my life. So I'd always been interested in public health. I had read a novel actually called Outbreak, and I thought it would be really cool to study Ebola, which is of course a hemorrhagic illness that is, outbreaks occur occasionally in Africa, and I was pretty obsessed with Ebola. I read a lot of books about it. Basically, I wanted to investigate outbreaks, and that's how I initially became interested in medicine. And so obviously, that's public health. But when I got to medical school, I sort of forgot about that public health connection and really focused on the direct clinical care. And so when I decided to leave surgery, I wasn't sure what clinical specialty I wanted to do, whether it was internal medicine or family practice. And I said, why don't I take a year and get my master's in public health and then sort of regroup? And early on in the master's in public health program, I learned about this specialty of preventive medicine, which I'd never heard of before, even though UCLA's medical school shared a building with the School of Public Health. I just didn't have any exposure to it. So I got really excited that there was a specialty that involved public health and treating populations and thinking about policy and how to prevent disease instead of just, throwing medication or, taking someone to the operating room to fix a problem. And so I got my master's in public health degree, which is a one-year program if you already have a doctorate. And then I finished a residency actually at the state health department, where I worked part-time for the state and part-time for a county, and really just got to see what we do in public health at the local level and the state level to try to keep people healthy in California. And I really liked that. So I stayed on at the state health department for about 10 years. I took a little break in the middle of all that because I was really interested in food policy and the connection between healthy, affordable food and prevention of diseases like heart disease, cancer, strokes, diabetes. And I actually became an organic farmer for a couple of years. I worked for minimum wage to learn how to farm, and then I ran my own farm for a couple of years. And I always saw farming as part of public health. It was about increasing access to healthy, affordable food. And I had a farm stand. Actually, my farm was in West Sacramento. And it was in a low-income neighborhood right across the street from an elementary school. So I had a little farmer training program for the kids, and I sold the produce at very affordable prices in a neighborhood that is what we would call a food desert. It didn't have a lot of access to healthy, affordable food, a lot of fast food, but not necessarily grocery stores or farmers markets. So I did that for a couple years, and then I decided I couldn't make a whole lot of money as a farmer, and so I decided to come back to full-time public health work, and I I ran a training program for other public health doctors and people who wanted to be data scientists or epidemiologists. And then I had a chance to work instead of at the state on like one disease at a time. I had a chance to become a local health officer and get to do a little bit of everything on any given day. I could be dealing with measles, tuberculosis, COVID-19, another infectious disease. I could be looking at tobacco policy. I might be looking at how do we, have a more trauma-informed agency so that we can better serve our clients, and how do we support our staff as they're dealing with, the world, budget cuts, the trauma of supporting folks through the pandemic, for example. So I have the opportunity to work on in a lot of different areas. We also, in public health, it's not just infectious disease. We're also preventing chronic disease. We also work with children and moms. And so I have the opportunity to influence policies in all of those areas, which is a lot of fun. So that's kind of my path to where I am. As I said, it was not a direct journey. I thought I wanted to be, a cardiologist or a family practice doctor when I went to medical school, and I ended up becoming a surgeon. And then I realized I didn't want to do that after all, and found my path in public health. And even, in public health, I was at the state level for a long time, and then realized that, I really like being at the local level and having a, more of a surprise, on any given day. What I think my day is going to look like could end up being completely different. For example, if there was a wildfire that started tomorrow, I would probably be working with the air quality agency to put out a press release about the quality of the air and how that impacts people's health, and the challenges of breathing smoke and how that can increase the stress on our bodies in terms of our cardiovascular system as well as our lungs, and encouraging people to stay inside with their air conditioning on and potentially a HEPA filter running, and to wear a mask, a high quality mask like an N95 if they go outside, and not to exercise outdoors. So or, we could have a measles case. We currently have this kid who's being tested for measles. And so I might get a call from the lab this afternoon telling me that this kid has measles. And now I'm going to scramble to get our team together to figure out everyone that they came into contact with and anyone who's at risk of measles, trying to figure out how to protect them within 3 days. So I think that's the fun part of my job. But if you like, to know what your day is going to look like when you wake up in the morning, probably not the best choice. But for me, the most rewarding thing about public health is because I was contrasting the work that I do with the whole population to individual patient care, is knowing that at the end of my day, the things that I've worked on have the potential to help and to protect the health of everybody who lives in Yolo County, all 225,000 people, which is a much bigger impact than I could ever have one patient at a time in a clinic. So for me, that's the best fit, and it's something I love doing. And I am going to stop there because I want to hear from you guys. Any questions that you have?
One came to me. How do you cope with the stress of this job?
Yeah, that's a really good question. And it's something we're spending a lot of time talking about. I talked about this trauma responsive work that we're trying to do, and recognizing, actually, I was down in Pasadena supporting first responders who saw really difficult things in the wildfires in January in Pasadena, the Eaton fire specifically, and creating spaces for them to share their experiences. And one of the things that we talk about with those folks is how important it is to take care of ourselves. I just flew yesterday, and one of the things when you get on a plane, they always tell you put your own, if you're traveling with somebody, a child or, someone who is disabled, to put your own oxygen mask first, and I think on first. And I think that's such a lovely metaphor for what we all need to do in this challenging world, whether you're a physician, whether you're a high school student. There's a lot of uncertainty, and uncertainty is stressful. It's hard on our brains and our bodies. And we need to take care of ourselves by putting our own oxygen mask on, because if you're not taking care of yourself, you can't take care of others. And there's this, a lot of people think, oh, taking care of myself is selfish. It's not. It's essential. It's the only way that, you can be there for others, is if you're taking care of yourself. So for me, I think about three things. I think about moving, breathing, and connecting. So I play soccer and I like to run. And so I like being outdoors especially. So I will go for a run, I'll go for a walk, I'll spend time with my dog. I like to head out to the river and be in nature as I do those things if I can. I do deep breathing exercises, anything that where your exhale lasts longer than your inhale is going to be relaxing for the body. In terms of how it impacts your nervous system. And then one of the things that we know is that as human beings, we're hardwired to connect with other people. We evolved around others, and that's what soothes our nervous systems. And so I talk to somebody, I call a friend, we get together, I spend time with my fiance, I share with them what's happening. I also have a therapist who I can talk to. So those are, some examples of the types of things that I do to take care of myself. But I have colleagues who do lots of different things. But I think what's important is that each person sort of recognizes what's helpful for them, and sort of builds up a practice and has a set of tools and people that they can turn to help them manage stress. But we may think that we're islands and that we don't need people, but we really do. It does. Connection mitigates trauma and stress.
Good. It looks like Colin has a hand up. Go ahead.
What do you think is the biggest threat to public health right now?
Oh, that is a really good question. It's hard to pick just one, Colin. I think big picture, climate change is the biggest threat to public health as we look at warming temperatures. That directly impacts air pollution. As temperatures go up, ozone levels go up. But it also, we have more heat waves, we have more forest fires, which encroach on our urban areas. We are seeing spread of infectious diseases. In California, something like dengue fever, which is typically in the tropics in South America. We had locally transmitted dengue in Southern California. So normally we'll have a few cases a year. People travel to Mexico or to South America or Puerto Rico, and they come back infected with dengue. That's one thing. Now that dengue can be transmitted in Southern California or even in Yolo County, because we have the mosquitoes here that can transmit it. So we're going to see more of that old diseases, but in new areas. We're also seeing like an increase in valley fever. So I think big picture, climate change is going to be hugely disruptive to our health. People being displaced because of sea level rise, for example. But I think in the short term, the biggest threat to public health, it's hard to say whether I want to just say it's budget challenges, not having enough money to do what we do, but also individuals in positions of authority who are working very hard to undermine the work that we do in public health, particularly when it comes to vaccines. There have been a lot of recent changes announced at the federal government about COVID vaccines and about other vaccines, and a lot of people who were serving as experts on committees for the Centers for Disease Control were recently kicked off of the committee and replaced with folks who have a lot less experience and expertise in vaccines. And so there's a concern that, you know, vaccines may not be as readily available. They may not be reimbursed by insurance companies. And, you know, the reason why we have vaccines is because they protect people from infectious diseases. And we're already seeing, you know, the vaccine hesitancy with MMR, for example, is increasing the spread of measles. And now there are large outbreaks of measles in Texas and New Mexico and Oklahoma as a result. So I think we're, you know, if this trend continues, we're going to see a lot more people getting sick and potentially dying from infectious diseases that we have the ability to protect against with vaccines, but people aren't getting those vaccines.
Okay. I have another question here. How do you collaborate with other fields of medicine?
Yeah, great question, Mahmoud. It is oftentimes on consults with providers. I would say is probably the most direct collaboration that I have. So I described that phone call with a pediatric nurse practitioner with a question about her kid who she's seeing in clinic that she thinks may have measles. I get that about tuberculosis, which is another illness that I'm responsible for in Yolo County. I also have regular conversations with the leaders of the 2 hospitals in Yolo County. We have Sutter Davis Hospital and Woodland Memorial Hospital, and I meet with them at least once a month to talk about what's going on in their hospitals, making sure that they have procedures in place, for example, where they're going to catch someone with potential measles at the door and put a mask on them and send them directly to a negative pressure room so that they don't sit in the waiting room for 2 hours spreading measles to everybody else. So that is another collaboration that I have with providers. So I think there's probably just about every specialty I come into communication with because, I mean, it could be a surgeon who ends up seeing a patient with tuberculosis, but it's oftentimes it's inpatient and outpatient. So patients in the hospital, usually on pediatrics, family medicine, or internal medicine. But yeah, I'm definitely, even though I don't sit in a clinic, and I'm really one of few physicians who works for Yolo County, I am in close communication and collaboration with lots of fields. The other thing that I do is send out health alerts. When, for example, we saw monkeypox or mpox in our wastewater in Woodland about a month ago, I sent an alert to every healthcare provider in Yolo County, letting them know that there was probably mpox being, or someone with mpox in our community, and reminded them what the symptoms of mpox are, what it looks like, and how to test for it, and gave them my cell phone number so that if they did see somebody that they thought might have mpox, they could call me right away and I could help them figure out what the next steps were. So that really is collaboration across every field of medicine when those alerts go out to people who have signed up to receive them. So hopefully that answered your question.
All right. Well, we're just at time. So thank you so much for sharing your story with us. You have such a crazy path to end up where you are, and it's really cool to hear. So thank you for taking the time to share that with the students.
Thank you all for being here and for listening. And since this is your last session, I hope you have a great weekend.
Yes. Well, thank you very, very much. Have a great afternoon and weekend. And guys, that concludes our day. So the winner of the gift card is, let me pull it up, Alexandra Kirchie. So I will go ahead and send you a card. Everybody else have a wonderful afternoon.